Thank you, Aiman, Sarah, and Suma and Ali. Very fruitful and extensive neurology session. So again, I will do like Aiman, one by one. I will ask a question. So the first question for Dr. Aiman Rahmani. There is one thing you said in your talk that do not wake the baby up and sleep. So what about the feeding? Because this is the common practice that they wake the baby for the feeding. And not only that, if the baby taking the feeds and go to sleep, so what they will do, they will put the NG and begin the rest of the feed. So what do you think about that?
So initially, if you feeding the babies for like every 2 hours, it's not really you have to do it every 2 hours.
Yeah.
And you can actually, if you're feeding in G tube or OG tube, you can feed without waking up the babies because you don't have the cues to be developed at that time which give you indication that the baby is hungry. When the baby gets older and you get flexible like timing between 2 to 3 hours, you can wait a little bit if the baby is sleeping until they wake up. And the best time to feed the baby is when they're actually kangarooing with the mother. So this is the best time when you feed the babies, and this is actually time when the baby sleep. The baby can fall asleep, and then they can be fed during sleep. When I'm talking about waking up the babies, is that I don't know if we bundle the care enough in our units. When you have multiple disciplines examining babies and at certain different times. So what we're trying to do in our neuroprotection unit is that to bundle the care. So you do waking up the baby once for examination by physician, nurse, respiratory therapist, and you bundle everything together. So we don't have to disturb the sleeping too much.
Sure. Okay, my next question to Suma for you. NIRS, actually it's a very new here. I am not very humble to say I'm the first one who start using it. I'm very much convinced about, but just for the our audience and our participants, how you feel. I know you talk about it, but how you feel. It should be like a standard of care. It should be more evidence in this technology support. What do you think? And this is the question for a lot of audience from the audience.
Absolutely. That's a great question. I think that at this point, I don't think it should be the standard of care for every neonate in the NICU because, really pointing to what Dr. Rahmani said about, trying to have natural care, kangaroo care, NIRS would interfere with that. But I think there are specific populations that certainly can benefit significantly from that additional monitoring piece. So I think when you develop algorithms in your unit, looking at what is the population at highest risk and what are the times where they're at highest risk for adverse brain injury, and then can we add this monitoring at those time points in those specific populations. It also needs to be followed with a clinical algorithm for response to the numbers that you're seeing versus just things, I've seen it used in NICUs where people almost ignore the numbers and don't respond to it, and that's not what you want. You want it to be a useful piece of information. So it has to be incorporated into the overall care of the baby, presented on rounds and such.
Thank you. I will come back to you, Dr. Ali. Yes. You talk about multidisciplinary team approach, but the question is that we have different approaches and the neurosurgeons are involved. Do you think the decision-making power in the management of post-ventricular hemorrhage is the neuropediatric neurosurgeon or is it the neonatologist? What do you think? I know MDT approach, but still, these things are going on. And I need the comment of Dr. Aiman on that also after Ali.
Well, I think, and that is the international practice, is that these babies are in the neonatal unit and they are managed by the neonatal neurology. So the practice stays with the neonatal neurologist. For example, I was working in Bristol with Dr. Whiteline Southmead. They are the people who lead the team, and the neurosurgeons do contribute into it. They do have the say, but they have more say in terms of doing neurosurgical procedure. But when the intervention is needed, that is with the neonatal neurologist. But if you remember in my talk, I showed one framework at the end, and that framework has been agreed by the most of the internationally renowned neonatal neurologist and the pediatric neurosurgeon. I don't think there's another approach at this moment. New things may come up in the future. That's a different thing. But at the moment, the standard approach is only one, which is early intervention at early stage, taking into account ventricular index at 97 centiles and the clinical signs of raised intracranial pressures and the head circumference. So that's the framework which we all need to follow. And it is related to the neurodevelopmental outcome, which has clearly come up. The neurodevelopmental outcome is not good in those who are managed at late thresholds. Yep.
Yeah. So Aiman and Suma and also Dr. Sara, if you can, all three can comment on that, because this is a very hot topic here in UAE, the post-ventricular hemorrhage management. So Aiman, what do you think?
I think the first thing that you start with is to have a guidelines to have a standardizing the care, because you have different, even neonatologists, different training, different backgrounds. They all have this different ideas about when to intervene, how to intervene, and all that. So in our unit, we kind of sat down and say, okay, this is the guidelines that we're going to follow. Now, the decision to intervene, actually, it's a shared decision. It's not really one or the other. It's the neonatologist will initiate the monitoring, when to do the ultrasound, how to interpret the ultrasound. And we sit down with the neurosurgeon and we'll say, okay, so this is now we reach a threshold. And Dr. Rafi mentioned, there's no one way to proceed with the procedure. You try the repeated LPs and you have a 30 to 50% chance that you will have arrested hydrocephalus. That's not going to really need to be to have a hardware installed in the brain. And and then when you get some device to be implanted, then you talk to your surgeon, and they're going to be individualized according to the baby. Because some babies, Ommaya reservoir will not be an option. It depends on the skin, depends on skin condition, depends on the fragility of the skull and all that. Then you have to explore other options. Some, you use externalized shunt, some use Ommaya reservoir as temporizing until you get to the VP shunt. So it's all shared decision, and you have to include the family in the decision, because when you have a decision to put a VP shunt, that's not really the magic solution. You open a lot of problems in the future, with the infections, with the obstructions, with the issues. So that's that related to hydrocephalus. I just want to comment on the NIRS with Dr. Suma. We use NIRS in our unit, and we use it in selective cases. We don't really use it on everybody. We use it when we actually have, for example, like a PDA, we're not sure if it's really significant or not to treat. Or we have it as a kind of tool to tell us during blood transfusion if we really want to stop feeding or not to stop feeding. So I'm not really in favor of putting NIRS on everybody, because it becomes a number that's going to be meaningless and nobody will look at it, as you mentioned. So it's one tool that we use just to kind of add to understanding, because sometimes we use the blood pressure, for example, parameters that really doesn't make any sense, but they related to, for example, what's mean equal to gestational age, which didn't come from any evidence base. So if we have a low blood pressures, we say, okay, well, if you put a NIRS and it's affecting that blood pressure, need to be treated. Otherwise, we're just going to write it out, and then babies look at the other parameters like acidosis or something like that. So it's selective cases. I agree.
Sure.
Now, add
Uh,
to that selectiveness that, you know, the perinatal transition where they're at the highest risk for IVH development, you know, really could be, and that's where a lot of research has focused. And I think that could be an area of routine monitoring. And then it comes off unless you have those situations that you mentioned, could be a way to go about it as well.
Okay. Dr. Sarah, you mentioned about the CMV treatment. Can you elaborate a little bit more about the targeted treatment on Benzcyclovir? For 4 months, you put it in your presentation, or 6 weeks. We are usually treating for 6 weeks. Can you elaborate on that?
Yeah, so it's so that's for symptomatic babies. So I think I presented some data on some of the studies that are looking at some different time courses of treatment for asymptomatic children. But for the symptomatic children is what we do for the 4-month treatment.
Okay. Okay. I'm sorry because I have questions. I think I will email to you, all of you, because the organizers are saying that we are delayed because the next session is going to be started because they are from the different countries. Thank you very much, Dr. Sarah, Dr. Suma, Dr. Aiman Rahmani, and Dr. Ali Reza. Very well organized your talks, and we learned a lot from your this session of neurology. And I'm sure I will ask them to send all the questions to you, especially to Dr. Suma Hoffman and to Dr. Sarah, because these are the two very hot topic areas and the infection, and you will get some emails. So please don't mind if you answer those.
Oh, great.
Aiman and Ali, I can ask them later on. I will email them. So
Sure.
that's not it. Thank you so much.